Bismillahirrahmanirrahim. The topic I'm going to talk about is what I call very common in neuromuscular clinic. It's just like headache in neurology. There are so many patients in the community. Same way in neuromuscular clinic, I call it the headache of neuromuscular clinic because there are so many patients with paresthesia and numbness. It could be intermittent, it could be continuous, but this is a very common complaint, what we come across in neuromuscular clinic. So let's talk about that, and I will give you my input, how I approach these patients. First of all, definition, then how I approach it, some neuroanatomy, sensory examination and localization, investigation, and some pain management insight in it. So in terms of definition, I'll say there are positive and negative symptoms. For positive symptoms, it means there is burning, stinging, tingling, pins and needle kind of sensation. So paresthesia kind of is positive symptom, which is mainly feeling of tingling, pins and needles. But then there is loss of sensation in part of the body, whole body, some parts of the body, which is a negative symptom. Then the way I approach it is by history, as in all the neurology cases, examination, differential diagnosis, what are the investigations that could be done to approach it, to know the etiology of paresthesia, some treatment options, prognosis, and like in any usual neurological case, supportive care. In terms of neuroanatomy, sensory system is the one that connects us to the environment. So it's our interaction with the environment, which could be external, which could be internal. It is further subdivided into somatic and special sensation. Special sensations include our hearing, vision, smell of taste, and also it could be balance. The way that has been described by different authors is different, but I'm going to follow a general approach. Exteroceptive is what we have from the external environment interaction with our body. Then there's the interoceptor, which is the visceral sensation. There are osmotic receptors, stress receptors, which can kind of guide us about the visceral sensation or internal environment of the body. And then there is proprioceptive input, which is mainly concerned with the movement, motion, and position of the body in the space or the organ in the space. It can, as I already mentioned, can be divided into somatic and visceral. Somatic is external environment, visible is primarily internal environment. It could have a conscious or unconscious component, like talking about proprioceptive, the posterior column or dorsal column is conscious, but the spinocerebellar tract is the unconscious component of it. Receptors, there are many types. There are mechanoreceptors, there are thermoreceptors, chemoreceptors, photoreceptors, osmoreceptors, which all these receptors are supplied, I'll say one nerve extension supply multiple receptors, and those receptors respond to multiple stimuli. But the threshold that stimuli can create an action potential in these receptors or change in the receptor going to be different. So based on pressure, touch, that varies based on the receptor type. So threshold or the threshold of activation for these receptors vary with different stimuli. And then these receptors are supplied by one nerve twig or different nerve twigs. In terms of neuroanatomy, I'll say this is what I have just explained. So if there are proprioceptive endings, which mainly comes from the muscle spindles, and it mainly goes into the dorsal column and kind of usually ascends on the same side of the spinal cord. Nociceptive and thermal endings, which mainly carries the pinprick, pain sensation, thermal sensation, it kind of goes into the dorsal column, but it actually goes to the other side of the spinal cord and extend upward as anterolateral system or spinal thalamic tract. Visceral endings kind of stay on the same side, but because of visceral endings that carry sensation from the visceral organs, multi-pathway connected, So it gives you merely vague and not a localizing value to assessment of sensory nervous system. But the proprioceptive endings can give you more dominant assessment of the sensory localization. Same goes for the sharp pain and touching temperature. Axons can be divided into different types, and there are different classification systems. One is by Sherinkton, and there is also can be divided into 1 to 4 different types, where 4 is the unmyelinated C fibers. It can also be divided into A, B, and C, where the A alpha and A gamma are motor fibers, but A beta and A delta are sensory small myelinated fibers. And then there are unmyelinated C fibers. The conduction velocity varies based on the type of myelination, extent of myelination, and diameter of the axon. So that's why knowing what particular sensation going to be carried, or sensory modality going to be carried by what fibers, and will that fiber we will be able to assess by regular nerve conduction study or not, is helpful. And that nerve test is affected by the diameter of the axon and the degree of myelination. As I already mentioned, there are positive or negative symptoms. I already talked about what positive symptoms could be, and negative symptoms are primarily loss of sensation. And we are mainly talking about the sensory examination and sensory system. The different sensory modalities that we check or that can be assessed are pain, temperature, light touch, pressure. These primarily go through the spinal thalamic or anterolateral system, and the vibration, position sense, proprioception, sometimes deep pressure can be carried out by the dorsal column. The way I kind of assess is I tend to do the sensory examination at the end of my clinical assessment, because especially with the sharp pain assessment and all, it could be very painful and also annoying for the patient. So I tend to develop rapport with the patient before I actually proceed with the sensory examination. But many different authors and colleagues feel that it is the most difficult and tedious part of the neuroexamination. And the biggest reason for that is it is highly subjective. And it depends on what patient going to tell us. So patient has to be comfortable in a quiet room. If you want to lay down the patient, that should be okay. Sometimes I like to examine my patient in down for the more detailed assessment, especially in case of patchy paresthesia. Having some side information, like if you do the pinprick exam and patient withdraws, that also gives you a clue that the patient felt the pain. Was patient ticklish when you were doing the Babitsky sign, could be helpful as well. So all these can give you some side information in terms of sensory examination. But as I already mentioned, try to avoid any distraction. You can do shielded examination or ask the patient to close the eyes while doing your assessment. And also ask the patient, is it primarily pressure sensation that patient feels? As a matter of fact, the patients who are having non-organic abnormalities, look for the behavioral issues, especially inappropriate affect. That can kind of give you a clue. But there could be some mild sensory changes too. So be mindful of that. I also say the trophic changes in these patients, especially in terms of having foot ulcer, some wound, or some other calluses, would be helpful to know about knowing the extent of the sensory damage, because if patient didn't feel the ulcer or the pain because of that, that means there is sensory abnormality in the feet or that part of the body. As a matter of fact, you can assess these patients in many different ways, but I tend to examine the normal part first, so they have the feeling of how it's going to feel like. And then I assess the abnormal region of the body, which is the main area of concern for our examination. There is always this question of doing distal to proximal sensory exam and comparing one side with the other side. But based on what patient going to tell you on history, you can kind of cater your examination. But there is always this question of either you are doing too much or too little of assessment for the patient, which kind of varies by complaints, what you're looking for, how high your suspicion is. But we all know for the non-organic patients, you tend to examine to make sure that there is no point left. So you tend to be more thorough in those cases. Investigations in these patients, I like to go step by step, but for this particular presentation, I have it as a localizing kind of examination, but naturally there is a lot of overlap in the sensory assessment. So please take it as a guide, but this is not exactly reflects in a clinical setting. The first part is about the peripheral nerve. So most common reason for someone to have peripheral nerve involvement is diabetes. And we know that our big size of the population, almost 10% of people more than 40 years of age have peripheral nerve involvement because of the sensory motor changes or sensory changes. So diabetes is the most common one. Pre-diabetes, as you can see, the number 33.9% in US population. Same goes for the metabolic. So combined together, metabolic and diabetes can constitute more than 70% of the patients with the peripheral nerve involvement. The additional reasons or etiologies could be ganglioside antibodies, especially GD1B, GQ1B, anti-MAG antibodies, protein and immunofixation or electrophoresis, primarily for dermatological malignancy or monoclonal gammopathy of uncertain significance. We can also do angiotensin converting enzyme for sarcoidosis. Autoimmune assessment is very important because a good number of autoimmune patients, besides having autoimmune problems like rheumatoid arthritis, they can have neuropathy too. Especially checking ANA, SSA, SSP for Sjogren's syndrome. In that case, it's primarily sensory dominant polyneuropathy, SLE, tissue transglutaminase antibody, and the smooth muscle antibody with autoimmune hepatitis. A small proportion of patients, I'll say very small proportion of patients do have paraneoplastic syndrome, but in paraneoplastic syndrome, sensory neuropathy is very common. But itself, paraneoplastic syndromes are not as common. So anti-HIL, anti-CCRMP5 antibody can be assessed, or the whole panel can be done in these patients where there is concern for paraneoplastic disorder. Rhodopsin deficiency or excess, either way, but primarily excess can give you sensory neuropathy. Chemotherapy is another big reason. Almost 30% of the patients who receive chemotherapy, they tend to have very painful neuropathy, which is hard to manage and refractory to many medications as well. Antibiotics sometimes, especially metronidazole, fluoroquinolones, and I have seen some patients in the past who presented with sensory predominant polyneuropathy. If there is a localization of the dorsal root ganglion, the assessment or the clinical evaluation going to have ataxia as a predominant symptom in these patients. Actually, the fiber tract that carries sensation from the peripheral nerve kind of divides in the dorsal root ganglion, and the proprioceptive and vibration fibers are more medial, and the spinothalamic or pain, temperature, touch fibers are more lateral in location in the dorsal root ganglion. So the particular testing that can be done if you're suspecting that is protection for Friedreich's ataxia, POL-D mutation for mitochondrial disorder, vitamin E deficiency, acquired or genetic, hypertriglyceridemia, which could be acquired or genetic too, AAP6, again, on a mitochondrial disorder. But there are some infections as well, like HIV-1 and also HTLV-1. VZV and leprosy can also give you dorsal root ganglion predominant involvement, but as I said, there is many times overlap in the clinical setting. When it comes to dorsal column involvement, vitamin B12 deficiency, which can also be assessed by doing MMA and homocysteine level, because sometimes the vitamin B12 level is low normal, but MMA or homocysteine could be abnormal, could be helpful. And it's a very common cause or acquired reason to have dorsal column involvement in patients with severe ataxia. Copper level, folic acid level, thiamine deficiency, vitamin E level again, FTA, ABS antibody for tabes dorsalis, HTLV1 and 2 can also cause dorsal column involvement. One way to tell between vitamin B12 deficiency related dorsal column involvement compared to tabes dorsalis due to syphilis is that vibration is much more affected in patients with vitamin B12 deficiency compared to patients with tabes dorsalis, where there is primarily loss of pain sensation. So there is some differential that can guide us. In general, these patients, I tend to do nerve conduction study to see the extent of neuropathy, or is it like predominant large fiber neuropathy? But many times with the large fiber neuropathy, there is small fiber involvement. So it's good to have the baseline idea of the extent of neuropathy. Lumbar puncture can be done in patients where there is concern for autoimmune disorder, also in patients with paraneoplastic or neoplastic disorder for the assessment of infiltration of the nerve roots. Somatosensory evoked potential is, I think, very underutilized in refractory or unknown, undiagnosed cases, which I think should be used more, because many times there is a root involvement or more dorsal column involvement. In that case, medicine cerebral potential could be more helpful in localizing it, beside history and examination. Again, brain and spinal cord imaging can be done if there is concern for dorsal column involvement or there is a more diffuse process having cerebellar involvement. Genetic testing, I tend to do it much more frequently for my patients, especially when there is concern for amyloidosis or some other genetic, like SCN9A related neuropathy or small fiber neuropathy. Skin and nerve biopsy can be done in cases to have more insight, especially in patients with vasculitic neuropathy when the antibodies are negative, which is the case many times in Sjogren's syndrome. In terms of the management of the neuropathic pain, pregabalin is the only medicine which has class A recommendation, but gabapentin, venlafaxine, duloxetine, tricyclic antidepressants, a couple of others are all class B. I tend to use one and then add on top of it. Next, your choice varies based on the patient's other factors, and you can kind of go from there. There is a recent update in terms of using capsaicin patch. Lidocaine patch can be used as well. I rarely use those. Carbamazepine is another medicine which I rarely use, but that could be helpful. I have never used benzoyl, but again, sometimes using combination is much more helpful. According to American Academy of Neurology, opiates or Botox is a class C recommendation for the management of neuropathic pain. So one should be careful unless you are having a high suspicion for refractory pain and patient is in a really bad situation. But usually I tend to refer those patients to pain clinic at that point to prescribe either opiates or do some invasive or high-end pain management therapies. Exercise, there has been a recent, a lot of emphasis on exercise and healthy lifestyle. As a matter of fact, it really helps the patient. As we have already seen, a good number of patients have metabolic neuropathy. So exercise is very helpful. It can actually reverse the neuropathy and they can have regrowth of small fiber if there is a small fiber. Some patients, when they are having refractory pain, not responding, and they have a really bad quality of life, spinal cord and nerve stimulation therapies can be tried. I've tried acupuncture in my refractory patients with some benefit too. As I said, botulism as toxin is class C evidence and should be used in the pain management clinic. I do have some cases to share with the audience. My first case was a 28-year-old male who had 1 month history of progressive gait disturbance. He noted a patch of intermittent numbness and tingling on his left eye that became constant, followed by numbness and tingling in his feet that progressed proximally and went up to his abdomen. He noticed some urinary urgency, constipation, and increased sensitivity. He recalled having a viral infection with orals 2 weeks before symptom onset, and he used to drink 6 to 8 drinks per week. He used marijuana in the past. Also, he was smoking tobacco, but denied other drugs. So looking through this detail, you can see there is some small fiber involvement, which is patchy, but he was also having some autonomic involvement in terms of urinary urgency, constipation, and he's very young to have this neuropathy, and it's relatively sudden too. It disappeared on 1 month. On examination, inchoate reflexes were diminished, which kind of goes with the large fiber involvement. Same for the vibration sense with the large fiber involvement, and patchy pinprick sensory changes, which goes more with the small fiber involvement. But very importantly, he had truncal ataxia with inability to stand without support and a wide-based gaze. He was so bad that it was really hard for him to even stand. So this was my first case. As you guys think about it, I'll talk about my second case. Second case was a 41-year-old male with alcohol use disorder and alcoholic liver disease, just to give the idea how much he was into. In late 2009, he noted trouble gripping pen, initially which spread into legs. And then over the 4 to 6 weeks, he was really bedbound. He was weak to the point that he was not able to turn the keys for his truck. He noted difficulty going downstairs, even till today. When he saw me in clinic a few years later, there was no dizziness with weakness. He noticed some muscle soreness in the legs, but no tingling pain sensation. But what happened after that initial episode, he noticed this burning, stabbing pain a couple of years later, predominantly in his lower extremities, involving feet and leg. And pain can happen randomly in fingers and sides of the face as well. So kind of some small fiber, some large fiber, but initially it was just motor and then the sensory, which came up after a couple of years. There was history of heavy drinking in the past, which he quit in 2023. He was drinking to the point that he really want to help pain, so he was drinking a lot. There is history of erectile dysfunction, so some dysautonomic dysfunction. He was using IVIG with some improvement in fatigue and weakness, and he was on a good dose of gabapentin. On examination, he had deep tendon reflexes were diminished in upper and absent in lower extremities, so lot fiber involvement along with the pinprick was impaired in upper extremities, which improves so a lot of sensory changes in this case. Pinprick was impaired in lower extremities up to knees, which kind of goes with upper extremity changes as well. So talking about this particular scan from the first patient, and as you can see, you do notice this enhancement, I'll say hyperintensity of dorsal column. And you do see changes on the axial as well as on the sagittal scan, right cervical spine. So when we did the workup on this patient, he came out to have very low vitamin B12 level, and he later on confessed to using Whippets, which contains nitrous oxide and is known to reduce vitamin B12 level. And probably he was already having low vitamin B12 level, and he used it, and that suddenly drop in level caused this condition for him. And he responded very nicely to B12 supplementation. Second patient, his PEth level for alcohol was 671, which kind of tells us how much he was drinking or in habit of drinking. But additionally, his folate level was 2.5, which goes with small fiber involvement. Also, because he noticed some so his GE1B antibody was positive, so he was having more than one pathology in his case. So we need to work as a multidisciplinary team, taking care of his folate level, making sure about his alcohol habit, and also treat him for his immune condition. At the end, what I would like to say, I really like this photograph because it kind of shows all the ducks are in the queue, and there's only one which is out of the queue. And trying to pick the pattern of knowing what is out of the queue is what's helpful. So if any patient is having rapidly progressive symptoms and age, which is not like young age, or in case patients having a lot of ataxia, which kind of says there is a spinal cerebellar tract involvement or dorsal column involvement, and assessing all those modalities is very, very helpful. I will also say when I examine these patients in terms of modalities, for the pinprick, I tend to use sharp to pick. But do remember, other than the sharp pain, patient may feel the pressure, and you have to confirm with the patient, is it the change of pressure or is it the sharp pinprick sensation that he feels or able to appreciate? Or where does that deficit is and the extent of the deficit? Similarly, for the position, you can do the parietal copy test where you can ask the patient to close eyes, and on one side, you can OK sign for the patient while the eyes are closed for the patient with the hand, and ask the patient to do the same with the other hand and see if he's able to do it. As a matter of fact, if a patient is having a position-related deficit, patient may tend to have pseudo-acidosis kind of where they are not able to maintain a position, especially with the eyes closed, can also be another finding. Also, if we do the tandem gait and Romberg sign, those are going to be abnormal too, especially ruling out that there's a dorsal column involvement or not. So these tests could be helpful. There is another test with the name pinch and press test where you can pinch the skin, but not to find that patient feel the pain, but also you can press the skin and ask the patient with eyes closed what he feels and what he doesn't feel. I use 128 Hz tuning fork, and you have to check the distal first, but also give the idea how you're going to feel like by checking proximity in the hand. That's what I do. For the proprioception, I tend to check the knuckles. Also, I check the great toe at the interlingual joint or area. But do remember, if you are pressing too hard, there's going to be pressure sensation, giving the clue to the patient. But if you are taking care of all those confounders, then you can assess whether there is proprioceptive abnormality or not. I hope this lecture will be helpful for the residents, students in general, how to approach a patient with paresthesia, which is a very common complaint in neurology and neuromuscular clinic. Thank you very much.